I'd like to call the reconvened meeting of the board to order. Although a quorum was established on March 28th and the meeting is for informational purposes only, I'd like the secretary to please call the roll to recognize those directors who are present today. Madam Secretary, please call the roll.
Director Curry.
Present.
Vice Chair Deere. Is absent. Director Garza.
I am present, yes. Thank you.
Thank you. Director Guggenheim.
Present.
Director Harrington. Director Harrington, you might be muted. I see you on the screen. I'll follow up with him. Director Kim is absent. Director Ketting.
Present.
Director Munar.
Present.
Director Prendergast.
Present.
Director Ryder is absent. Director Story
Present.
and Board Chair Taylor.
Present. Thank you. The purpose of today's reconvened meeting is to continue receiving and discussing the information on the work being done to date on the strategic plan. When the meeting convened on March 28th, the board received public testimony and reviewed the presentation on the environmental scan by CDPH. The presentation under agenda item 4 was partially reviewed. So today we will continue that review and discussion. An updated version of the presentation was distributed and posted on the CCH website. Slide 51, we'll note, is new. And a couple of the slides relating to the county care were updated. So for those who want to call attention to those things for everyone, I believe we're ready to begin the review by Aaron Galina of the information regarding county care, starting on slide 28, I think, Madam Secretary. Mr. Galina, are you present? Madam Secretary, we seem to be going between a technical error, slides 3, 5, and 6 here.
Yeah, it's not handling this well. Hold on one moment.
I think I fixed my audio problem. Can I be heard?
Yes, we can hear you. Thank you.
There we go. Thank you, Chair, and good afternoon, directors. So I wanted to provide similar contextual information as you received with the Department of Public Health and the CCH in the last board meeting. So starting with County Care's historical membership, this shows our membership since the inception of County Care. You'll note there's been a couple periods of significant growth, both back in 2015 when we moved from just serving the ACA population to also serving the family health plan and ICP populations. And then in 2018 when there was an acquisition of membership from Family Health Network and Aetna Better Health, which increased membership at that time to around 300,000. And then of course, more recently, we've had significant growth as a result of the pandemic. The next slide shows our membership information since 2018, but adds a line for the trend in the market share during that time. So you can see a relatively stable market share trend until, again, more recently, as we've seen our market share increasing. On the next slide, again, just showing our current membership through March when we were at 429,000 members overall. About 45,000 of those members impaneled to our Cook County Health clinics, and with the family health plan population making up the largest proportion of our overall membership at 264,000. Next slide, Deb. This is a summary of our utilization over the past several years. This is in raw total, so it's not adjusted on a per 1,000 basis. But for 2020, you'll note either flat or decreasing utilization as a result of the pandemic, and of course we were having growth in membership at that same time. And then 2021, you see more normalized utilization. And again, a little bit higher, reflecting the growth that we've had overall in our population. When you adjust 2021's utilization for the membership growth, you see we've had a decreasing trend overall. Not a huge decrease, but a slight decrease, particularly on the inpatient utilization per 1,000. On the next slide, this shows our, and we're gonna test your eyes here, but on the left-hand map, this shows our overall county care membership density with an overlay of the CCH clinic and facilities. The right-hand side shows where the concentration of members are that are paneled to the CCH clinics. So left-hand is county care's population overall, and on the right side of your screen is just those members empaneled to the ACHN clinics. So you can see overall our populations, generally concentrated in the west and south parts of the city. And that trend generally tracks for the overall CCH membership as well, though more related in the immediate areas of the clinics. The next slide shows our overall hospital admissions to give you a sense of where the volume in our network is happening. So University of Chicago continue, as it has for the past several years, to be our highest volume hospital overall, both in terms of admissions and in overall paid amounts. And just a note here that the admissions are showing total days. Next slide shows inpatient experience by major categories. So pregnancy and newborns make up the greatest single item, followed by behavioral health, and then circulatory, respiratory, and nervous, and then digestive. About 2/3 of the family health plan admits are related to deliveries for pregnancy, where ACA, the largest proportion of that is generally behavioral health and mental health issues. The next slide shows primary diagnosis for hospital outpatient. So chronic kidney disease is our highest overall cost item here, followed by issues around pain in chest, abdominal, and pelvic pain, and then substance use and other disorders. Next slide, Deb. This shows our chronic condition categories for members that are empaneled to our ACHN clinics. So you can see, and this tracks generally with our overall county care population as well, with diabetes and asthma really being the top two disease categories, followed generally by behavioral health issues, although you'll see in these categorizations that a number of behavioral health issues are split into more specific categories, such as substance use, schizophrenia, major depressive, and bipolar disorder. Next slide, Deb. This is sharing information from our health risk screen assessments. This is specific to adults. So on the far right-hand column, you can see some of the social risk factors that are flagging in our health risk screens, including here, one of the largest categories is a BMI of over 30, as well as identifying issues in, lack of transportation, food insecurity, housing insecurity, and also, rating their overall health fair or poor. The next slide shows the same information for the children population. And really here, help with food, clothing, and shelter is the top category that comes up, followed by lack of transportation. Next slide. So this shows our ED utilization mapped by, again, by density of visits. And so really in the west and south areas, and this will be a theme through the next several slides, we see the highest ED utilization per thousand in our total membership. The next slide shows inpatient admissions. And again, you see sort of similar trends in terms of density. Of course, this also tracks somewhat relative to where hospital locations are. But you see the density sort of following the general trend of the other mapping. On the next slide, we show PCP visits per thousand. And so this sort of shows the inverse, where the greatest area of need or potential opportunity, or where we have the lowest PCP visits per thousand, again, are really concentrated in the southern part of Cook County. The next slide shows, Director Harrington, you had a question?
Yes, could you go back to the last slide? I'm looking at this red area here. That's where the University of Chicago is. Is that correct? I'm trying to understand, because earlier that it seems like they get the bulk of our covered patients go to the University of Chicago, and it seems like that's the area in dark red there. I'm assuming that's
yeah, that would overlay. That's correct.
okay. Thank you.
And then on the next slide, so this shows by disease state, and again, you see similar, west and south sides, particularly in the city, are the highest density of members we have with asthma or COPD. The next slide shows the same information for diabetes, and again, you see the same trend, maybe a little more concentrated in the west side here. But again, south and west are the highest density in terms of members we have with a disease state of diabetes. And then our final slide is showing similar information, again, by zip code, but for major depressive and bipolar disorders. And again, you see the similar concentration in terms of the map and south and west sides. Director Teddy, you have a question?
I have a question and a comment. My question is back on the slide 28, where it shows a cost per admission. Why is U of I such an incredible outlier?
Let catch back up to the slide. So University of Illinois, at least during this time period, has a unique inpatient rate. So their rates, which is based on their cost reporting with the state, is quite a bit higher than most of the other hospitals. That has been more recently changed. So now the state's adjusted that to be similar to sort of the market average, but they get an add-on directed payment in some ways similar to the way Cook County Health does to make up that difference. So it's really related to the rate that U of I has on the Medicaid fee schedule.
Okay, that's. I just note that hospital almost literally across the street's getting a much higher rate than Stroger. And it's funneling through our economic. So it is what it is. My comment is just to looking at the BMI over 30, the risk factors there. Over 40% of our adult population with a BMI over 30 and 5% of our pediatric population. I think there's some reasonable discussion about how critical that BMI is for defining health risk at the individual level. Nevertheless, those are really arresting numbers.
Yep. Director Harrington?
Yes, I'm looking at slide 37, and I had a question about it earlier. I don't see hypertension on this list, and I know that most people that have diabetes, a significant number of people that have diabetes have hypertension. Is this because there's some kind of emergency, or people have missed a visit, or they're trying to monitor their hemoglobin A1C? I'm just trying to understand what's going on with diabetes, which is related to chronic kidney disease.
Yeah, so your question is specific to hypertension. Yeah, I think it's likely related to the way that we're rolling up the HCC categories. So I can take that as the takeaway to split that out more specifically.
Okay, thank you.
And then Deb, I think we had ended on my last slide for county care. Yeah, that's it.
Mr. Chair, this is Director Deere. Can you add me to the roll?
Acknowledge, Director Deere.
All right. This is Andrea Gibson. Shall I proceed?
Please. Thank you, Andrea.
Okay. Well, thank you, Aaron. I think one of the things that we've heard a number of times from the board and from various stakeholders is, that we need to continue to look to increase the utilization of Cook County Health for county care members. And I think, Aaron's slides, affirm that for me as a key thing that we need to fold into the strategic plan. Moving to the next section, we wanted to get feedback on the pillars that we will use in the strategic plan. So as you know, we've gotten a fair amount of feedback from stakeholders. We've had a number of presentations and discussion and this is kind of how we organize the strategic plan that we'll be drafting and then bringing to you later this month. The last two strategic plans, the focus areas were grouped in the manner that you see on the slide. If you go to the next slide, Debbie. We asked in a lot of our meetings with stakeholders what was the most important, and we got some feedback. It's a lot of times the feedback is it's all important, but we have taken that information and we have a draft of pillars that we wanted to propose to you and if we go to the next slide, to organize our strategic plan. So to have 7 pillars. The first is patient safety, clinical excellence and quality, patient experience, workforce, talent and teamwork, fiscal resilience, health equity, community health and integration, optimization, systemization and performance improvement, and growth, innovation and disruption. So wanted to hear from you, any reactions to those pillars. or ones that you want to particularly emphasize in the strategic plan? And I don't know, Israel, if you wanted to comment on those as well.
Sure, I definitely want to just reinforce that we do believe that these pillars will be able to help us harness our plan, and we believe these pillars also give us are responsive to the needs we heard from the community and from this process, and really do put us in a position where we can concentrate some effort strategically across the entirety of our organization and all our operating divisions, and each one will be able to take pillars underneath this and expand the work that we want to do. But I'll pause there and definitely want to hear your comments and thoughts.
Looks like Director Harrington, you have a comment?
Yes. Two, slide 40, 49, those are not rank order. Those are just lists.
That's right. It's not
Sometimes
ranked.
Okay, so there's no rank order. And when you talk about disruption, I'm sure we're not planning to cause disruption, but I'm assuming that it means that we will deal effectively with disruption.
Well, actually, it's a little bit of both. We want to disrupt some bad behaviors. So if there are things that have been left behind, things that have people who have been left behind, practices that prohibit people from feeling at home when they come to be able to get their healthcare needs met, or in some cases, things we may be doing that may not be able to optimize care. We want to disrupt those and replace them with new strategies that will ensure that everybody has access to the world's best medicine and what we're doing to drive things forward, and feel that they found a medical home, that they feel at home. So whatever we're doing that is not the best effects, we want to disrupt. So it is a little bit of both. We'll disrupt bad things and hopefully create new things that will enhance care.
Okay, that's helpful for me, but other people, if you share this slide with other people, you may want to let people know what disruption means.
Absolutely.
It looks like there's a few other hands up. Director Ketting.
Editing in a group like this could drive you nuts, or drive anyone nuts. But I am allergic to the use of disruption in that way. It's too open-ended. It's going to. I understand what Israel says, but I just find it a combination of not clear and annoyingly trendy without having a clear antecedent. So that's my editorial comment.
All right, thank you. Director Curry.
Yeah, I just wanted to, I had taken my own notes in 5 areas, and I'm sure they fit under one of these pillars here, but I just wanted to know or to confirm that. So in terms of, it might be driving digital transformation. I mean, that's going to be critical for us. That fits under one of these pillars, driving a digital transformation, just experience both for the organization's overall framework and the patient experience. And then we plan to be more competitive than we are today, either through product expansion and some of the other things that will differentiate the plan from our other market entrants there. And innovation is addressed pretty clearly here, which is fine, but organizational change is, and I think we've talked around that with some of the disruption in other areas, but affecting positive organizational change so that we're communicating a compelling vision and proactively managing that change to empower our workforce. And lastly, for me, it's going to be so critical for us to be one of the leaders from just healthcare to well care, which I think we're well on our way to doing that. But I want to make certain that we don't lose sight in that regard and all that we do there. And planning for the transition from fee-for-service to value, that path that we're on now, managing risk and guiding the organization toward some of the broader population health and equity goals. So these are just scratch notes that I had, so in no particular place, but I expect that we'll find these embedded in one or more of the 7 pillars.
Absolutely. What I would say is a lot of those are covered in the last pillar of growth, innovation, and disruption, and what we're wanting to do, and we'll look at how we can reward that to be more clear. But I think a lot of the other elements, whether it's optimization, systemization, and performance improvement, or the health equity and community health, and what we're going to be doing there, is central to that. So it will span probably every pillar on the transformation that we're looking to accomplish and we're looking to change. But definitely covered under the digital components are part of growth, innovation, and we'll look at we'll take the feedback on what we can do for disruption. But the reason is that it's very particular, is that we're wanting to do something very, very different than just transformation. We do want to, it's a big goal, and definitely don't want to say that you want to be the Amazon or Uber of healthcare, but we do want something that big because the changes and the challenges the changes we have in mind and the challenges we face are that big and require something that is holistically different than what we have done. So we'll find a way to maybe phrase that a little bit better, but that's what it's wanting to capture, that it is something substantially different that we're aiming for, that looks to address some of those perennial challenges that existed.
Thank you. Director Munard?
Thank you. This might be kind of a continuation of this discussion. I think one of the things that I've noticed in our current and past strategic plan that I kind of felt was missing was more around like market position, like who is our core customer and what is our system known for, and how do we want to, what kind of brand do we want to cultivate in the market to attract our core customer and position ourselves. And I think in many cases we've allowed kind of payer of last resort, or our values around being a safety net to drive that and to our pearl, because I think we're not reaching one level up to attract that insured low or middle income customer that might be attracted to our system by quality and value. And so I think, I don't know where that fits. It probably does fit in many of these buckets. So, I think kind of the market position, brand equity, kind of community perception might be part of growth and innovation, might be part of clinical excellence. Certainly it's a big factor for fiscal resilience. So not really seeing kind of how we're building out those buckets, but I do think we need to aspire to be more than just the safety net or system of last resort. I think there's a huge market for it. I think, as we see inflation going up and, kind of the middle class getting squeezed more and more with cost, anything that we can show the market that, they elect their delivery at our system, that's going to be, even a few $100 or $1,000 differential with our competition is a big deal. And I don't know how to build that argument, but I think we should aspire to it, because I think we're allowing our competitors to take up that space, and needlessly, because we do have good value, and we do have have a quality product that we can position in the market.
I absolutely agree. And I think some of that, definitely it's included in all of this, but I think some of that is, and we'll discuss a little bit, some of the framing, in the strategic plan is also a time to look at what you want to do with the mission statement, because what you're talking is overall who we are and what we want to represent to the community. So we have a little bit of modifications of that as we've seen, and we'll go over that shortly. We've seen a lot of organizations start to really shorten. The mission statement used to be this long paragraph that pretty much no one remembered, and they've really gone down to a sentence so that you can drill it into your team, and that's your hallmark statement that you want everyone to understand. And we've done a good job of that, but I think it really is right now around what you say, which is we are the organization that takes care of patients regardless of the ability to pay, and that is a safety net. And so if you asked anyone what we do, that is probably you're going to get that most commonly is the answer. And so if we want to stretch a little bit beyond that, we can look at how that can be reframed as part of this process, still holding true to our mission, our core value, and our ordinance, but giving something that is a new approach in how that's accomplished to our team to give them something to stand behind it. So we'll discuss some of that as well, because what I think you're aiming for is really the mission. What do you know? What do you do? And that is, we can talk about a little bit in the mission and see what some of the other organizations have done.
Great, thank you so much.
Director Story.
I know this slide is not a rank order, but if it was, I would agree with the top three, if not the top four. In particular, my concern around number three, being associated with CCH for the last 2 years, don't have a long history, but my concern is focused on the people who take care of our patients and their families. And I'm glad to see that talent and teamwork, that workforce development will be one of the key pillars going forward, Israel, and your work here with your team members and creating a learned workforce in a very, very competitive environment that's only going to get more competitive as we all experienced in August of 2021, the Great Resignation, and people making decisions about opportunities in the marketplace. And I think that because we have a large number of our employees who are credentially oriented or have license, et cetera, they're going to start, I believe, and younger, as we all know, we have an aged workforce, in particular in nursing, and that younger individuals will have a tendency to be more mobile. So I'm glad that workforce talent is at the top, that you all will be working on that whole space in terms of wages, salary structure, those environmental factors that will drive, talent into our organization, and that we will start to redefine those boundaries in terms of excellence in what we accept from the women and men who take care of our patients, who are the real champions. And I think it's very important that we build on that we want to have employees who are champions. Going back to your point about the mission, David, that we want our employees to be active champions of our mission, and as you said, Israel, to be able to have a mission statement that they can articulate in a very succinct fashion and stand behind it. Your words, not mine. So I'm pleased with what I expect will come out of workforce talent and teamwork, which will be all encompassing. As this is a tremendous challenge. But I think that one of the roadmaps to that success is having something like magnet status as something that we could aim for, that the whole organization can coalesce around. This is not a nursing initiative. Those institutions, as you know, Israel and others on the phone know, that this is magnet status is an institutional endeavor. And if we slip or trip, the whole organization trips and we all start over again. So I think that workforce talent and developing a learned workforce is going to be key in a very, very competitive market for talent going forward. So thank you for having it in the top three.
Absolutely, and I do want to give that one was especially in response to comments from our board, from our board chair, from the team that really needed to be one of the driving priorities. And I would say patient safety is always first, because if we can't do it safely, we shouldn't be doing it. And Magnet definitely does hit on those three. It does keep patients safer. It is clinically excellent, and it ensures our quality, and it bolsters teamwork and talent in our organization. So it is one of those examples. And I would say my firm belief is if we can't do it safely, we shouldn't be doing it. And that drives everything else.
Director Guggenheim, I think you have your hand up.
Yes, I'm having a lot of problem conceptually with this entire slide. And I think it's because I don't understand where we are, how we're proceeding. I need a flow chart for how we're constructing the strategic plan. And I don't think I understand what the definition of pillars is. And I don't see among these 7 items that are listed a real sort of equivalent. I mean, it seems to me a sort of oranges and apples bunch of things that might otherwise be called priorities. And I can't fit this into what it is we're trying to do at the moment.
Sure. So let me try to help a little bit, and definitely we can I'll do a follow-up conversation and sort of show we have some graphics and things that can help. But for a pillar really is something, these items are what we're going to ask our team to organize all their work. What are they doing to drive this? And then ask them at the end of the day, what have you done to advance each one of these missions in our organization in your terms? And there's going to be a lot of things that flow underneath this. So our strategic plan will have concrete variables like magnet and certain hiring goals and targets and expansions of service lines. All those will fall under this. But because we have such a varied organization that spans from an acute care tertiary hospital to a community hospital to a CIRMAC correctional health division to a public health department and a county care plan, we want to have uniting principles that are what the strategic plan will be built on. So the actual elements will fall underneath these, but we want every single division, line, service, and employee to be making conscious decisions about what they want to accomplish underneath these 7 things. And it's what will drive the organization. So when we ask first and foremost, what are you doing to advance patient safety, clinical excellence, and quality? We also want them to ask every day when they're making decisions or asking about lines or accomplishments that they want to achieve. Is this driving patient safety, clinical excellence, and quality? Is this driving a better patient experience? Is this advancing workforce and talent in our organization? Does this mean that we will be more resilient? Is this responsive to the equity in our community, our community's overall health, and are we integrating it into what we do? And is this something that can be optimized, standardized, and build on performance? And will this help grow and innovate our business? And those are the questions that you should drive in any strategic plan. They will be more one than other. And so the project, the plan, or the pathway will fall underneath these. But these are the pillars because everything we do should drive these outcomes. And then we believe these outcomes will lead to us having a stronger organization that bolsters our mission. And so we'll put more definition and more discussion about what each pillar more means. But that exercise is what we want every employee to say. You want to do X. Does it hit each one of these pillars? Where do you think it fits most? But does it do all these things? And we want every individual, when they're looking at their goal for the year and what they want to accomplish, have they touched each of these things? Because if we believe that if we're doing these based on the needs that we heard from the community, we will be there in meeting the needs of what we heard. And so these are like the main components, I would say, the key ingredients.
Yeah, and I'll chime in that in the last 2 strategic plans, we called them focus areas.
Yeah.
And we've ranged between having 5 and 7, and it's just kind of a way to organize the main activities of the strategic plan.
Absolutely.
Yeah. Okay. Thank you.
It's like when I call them pillars, because I think I just usually think of buildings and structures, and I'm very geometric, so I think of something that holds something up, and so those are the pillars that will hold up what we are as an organization.
Israel, just want to acknowledge that, maybe ask the question that under these things will be specific action items, right? We can then measure over time. There'll be indicators of success. Is that correct?
Absolutely, without question. Indicators of success, measures and metrics, and the projects that drive those measures and metrics.
Thank you.
Commissioner Deere?
Yes, thank you so much. I think this, just to give a 2 cent, I think these pillars look fantastic to me. A clarifying question that I have is, are these in any particular order?
So I would say right now, for me, patient safety, clinical excellence, and quality is always the foundation principle. If we can't do it safe, if it can't be excellent and is not driving quality, we need to rethink it, and that's your first no pass go. patient experience and workforce and talent are very critical in fiscal resilience. But so is health equity. I think they're all important. That's what we made in the top 7.
Right.
And everybody kind of calls to one. I'm pretty sure if you asked our CFO, the fiscal resilience would be really important to her. But
That's right.
I think that and I think Andrea loves a lot, but growth and innovation definitely is something that she looks from a strategy perspective. But I think that we want to have all importance. But for me, I will always say patient safety, clinical excellence, quality is the most important, because if it's not safe, it shouldn't
And I
be.
would agree. I would agree. And I really like that. I think it's bullet point number 5. I really like the health equity, community health, and integration. So your last statement and comment was certainly accurate. And my hope is that we can expand as much as possible what we are doing that's community facing, because at the end of the day, it's the community who are coming in that are the patients, right? And so, you know, I always had this dream, and you probably remember this when we first met, of a hospital without walls, right? One that, you know, the community is comfortable coming to, but that the hospital is comfortable going out into the community. And so in my mind, community is always a common thread throughout all of these pillars. But I'm glad that it's ranked up there in those top 7, but want to continue to push that, because those are our actual patients.
Got it.
I see Director Curry, you have your hand up. Is that a current hand?
It is a current hand after I've listened to some of the other comments. And this may just be structurally for me. At this level, is this where we introduce some of the verbs? You know, I'm so used to having verbs at the pillar level even. An example would be with the workforce, talent, and teamwork, and after listening to comments there, where the pillar itself would say something like develop a highly skilled, adaptive, mission-driven workforce, you know, some of the comments that we've heard here. Or will that happen at the next level as you drill down a little more to actually associate? Because the action and getting to these places require a verb of action saying this will happen. So.
No, absolutely. I think that we as strategy documents have been looking, we want to have some flexibility for the team to adopt to what it means in their level. So is it to recruit the best nursing talent anywhere would be something specific for our nursing to sort of roll up. We will add a paragraph that is much more robust in what workforce, team, and talent means, but we want everyone to be able to personalize it and the action to happen at the level of where they're operating. So our CNO should have her own definitions for what these things mean for her. Then we'll approve that as her document for the year. Same thing for the CMO, same thing for the CQO, same thing for our CFO. All of them should have elements and actions that drive this, and we'll adopt it with them. But we will have more explanation and action items of what we hope to accomplish, an aim statement underneath each pillar when we have the strategic plan that comes forward.
Thank you.
And I understand Director Garza is on the line and has a question.
Thank you, Andrea, for the acknowledgement. Yeah, and I apologize that I'm commuting and I have to do this by phone, so I'm not able to visually see it, but I did get the materials. Just one comment to follow up on what Director and Commissioner Deere said. I do appreciate the idea of, you know, going where the patient is at as it relates to the community, because we know that a lot of this work in supporting patients and their families has to do with the social determinants of health. And so, yeah, it's not just about what we do in our brick and mortar, but also how we support people outside of that specific environment. You had referenced integration of care, and it's something I had raised back in the fall, and I'm happy that it's in here. Could you just speak more about what your vision is for that, if you don't mind?
Sure. I mean, for us, our integration looks at everything. It's how we integrate our patients, how we integrate our community and support, how we integrate providers to build a network that is much more expansive, how we are building our overall collective footprint as an organization, and even how we work with our providers and even community groups, nonprofits, organizations. What can we do to build a network of support for our patients, and how broad can that expanse be to provide the most robust system of care and safety for our patients? And so the integration looks at how do we integrate that in all of our processes so they're seamlessly connected together, and that we are doing the efforts so our patients don't have to. And whether that is creating better interfaces, integration through a technology purpose with our providers who may sit outside of our system, like our FQHC networks and our primary providers who use our system and help take care of patients, whether they're members of our county care team, and how we create that facilitation and creation across our organization to better manage patients, or even from the public health department and how we can better have alignment with nonprofit organizations and community collaborators and the share and abstraction of data. So it really is how we bring everything together as a system to be able to use the full facets of everyone's efforts to have a large convening table for the betterment of health in Cook County.
Israel, thank you. That's a very thoughtful response. So if you had to, just based on your assessment, having been here now 14 or 15 months, how much of that work do you think remains to be done, or how much of that work is in place already, has been built out? So is it, if you had to put a percentage to it, is it, I think we're 25% of the way, or maybe 60% to go, or just a rough ballpark if you had to guess?
I would say I'm not sure on the percentage. I don't want to, because I would say that a lot of work has been done. If you looked at our overall work, I think we have a lot of great partnerships. But I would say this: I think we have a lot more work that can and needs to be done. So I'll leave it that way. I would say we have a substantial road ahead, because I don't think anybody actually in the country has gotten it quite right yet. And I think it's a place that we can be innovative, and we have much road left to travel. But I think we've come a long way, and I think we've done great things. We have like our hospice program, our home programs that are working, the great partnerships our public health department has, what our county care plan has done to be able to create innovations in the healthcare space. I think we've come away, but I think the road is long, and we have more to go. So that's what I think I would say, that we have a lot more work ahead of us.
No, that's fair. Thank you for responding.
All right, why don't we go on to the next slide, the next one after this. So as Israel previewed, we wanted to have a discussion about mission and vision. A lot of times in strategic planning, those are reviewed. And so just to remind everyone of what kind of establishes the mission is, it's reflected in the ordinance, that the authorizing ordinance. And as you can see, there won't be a quiz. Like, we're not gonna. It's a lengthy mission statement. And then if you go to the next slide, it shows kind of how we've distilled that. So this is our current mission statement and vision statement. And as Israel mentioned earlier, most people remember the first part of the mission statement, but definitely not the whole thing. So if you go to the next slide, here's some examples of some shorter mission statements from other organizations that we thought we would share as a reference point. And we can go to the next slide. So, and also as a reminder, mission is it's a formal summary of our values of an organization. Vision is a declaration of our overarching objective or goal. Some of our goals in this discussion are to ensure continued alignment to the county ordinance, and also to honor and represent our historic mission, but also that the mission should be easily understood and clear. And as Israel mentioned, CCH employees should be able to remember and repeat the mission. So with that, let's go to the next slide. We have a couple of ideas on the right-hand side. The first is provide universal access to the world's leading medicine and comprehensive services for all Cook County residents through service, education, discovery, and innovation. Or alternatively, provide universal access to the world's leading medicine for all Cook County residents. So any comments, discussion about this? Or Israel, did you want to comment first?
Yeah, and the real thing that I think is for us transformative, we have always said that we would provide care regardless of an ability to pay and that kind of mission. I think for us, we're now at a moment that we should strive to provide universal access. That's not prescribing a type of payer. That's just saying that no matter who you are, we want Cook County Health to be here for you. Whatever your payer, whatever your source, regardless of your ability to pay or not to pay, or whatever your circumstances are, we want to be your universal partner in providing healthcare, and that is our aim, that everyone is cared for. And not only that they're cared for, but that we're striving to deliver the world's leading medicine, and that we hope to be leading it. And we want to make sure that that's what you get, because it's not just about providing care or giving you the basics of care. We want universal access to the world's leading medicine, and that's something that we should push for. And whether that is in our county care plan or public health department or whatever it is that we're working on, we want to have those leading medicine and comprehensive services available for all of our residents. I think that's where it comes from, because what we've heard from the board and we heard from everyone is that we want to strive to be the best, to innovate, and to make sure it's available to everyone. When we're trying to distill it to a very short number of words that people could remember, this sort of came about. But definitely open for some discussion, or if the board really feels that we stay to what we have, really wanted just to have the discussion and think if this is something that could be, as we adopt it with every strategic plan, if this is something that is more in line with what we want to do.
Looks like Director Harrington.
Yes, my observation is I think change is good. A lot of times I think this change is a good change, something that people can latch on to and remember moving forward. The major difference between the two seems to be the second one is a very abbreviated version of the first, and what it leaves out is the issue of comprehensive services. And then it goes on to talk about the how of what we'll do, and that might be implied. So I could go with either one. If you're looking for something that people would remember, I think the second one is easy enough for people to remember. But again, it's a mission statement, and we can elaborate that in the rest of the plan in terms of the issue of comprehensive services and how we'll get this done.
Thank you. Director Story.
Like Director Harrington said, I could live with either A or B or one or the other. From a historical context, I am concerned and would be concerned about ability to pay. I think that is in this community, and from a historical perspective, and most of y'all on this call, except Israel, know more about Chicago politics and its environment than I do. I just don't know if you could put forth one of these options without referencing regardless of ability to pay or something in that nature. I think that is so ingratiated into the very core of what Cook County government, Cook County Health represents over 100 years. I just don't know if you can step away from that verbiage in this community. You might, and I know you all continue to socialize this amongst yourselves, but that piece I think would be problematic, especially when you talk about elected officials.
No, I get it. And I think we try to capture that in a different way by saying universal access for all Cook County residents. That means everybody. It means that everyone is cared for, no one is turned away, and everyone is served. regardless of the ability to pay, gets us back to the earlier conversation is, are we just a safety net? And we really want to push that forward to say that we're now at a point that everyone should have access to the world's leading medicine, and that's what we're going to do. No one is left behind. Everyone is cared for, and it's universally available to everyone. And that is what we are as our mission, and we'd like others to join us to make that happen. I think would be part of a new way of doing that. But you're right, it is something that's not without its changes. But I think that if we want to push forward and do world leading medicine, this is a thought. We could find ways to integrate it. That's the point of today, is to hear some of the feedback on that, because I do know this is different. It's a new way to frame it, but it's a new way to also challenge us to make sure that it's not just regardless of ability to pay. It's universal access, open to everyone, pushing the world's leading medicine for everyone.
So in a way that's not market tested, but could be a tagline to this, is more than just a safety net, right?
Yes.
It's not saying that we're not a safety net, but we're more than just a safety net.
Yep.
This is Director Prendergast. I like the second option. However, when I think we want to not only I agree with the universal access, and I think that's includes everyone. But I also think that we want to, because we want to cast a wider net, that we do need to include something about education, discovery, and innovation, because I think that is important. Because we are more than just a safety net, right? There is a lot of discovery, innovation, and that implies, best practices. That implies, state of the art. So I do. So if you add those on, it's really the same. It's really one without comprehensive services. And I actually think that is something that is probably implied when we say universal access to world's leading medicine. I think we could take out that part, but then I do believe that it's important to have that education, discovery, and innovation, because in my mind that's the next level. That's state of the art. That's reaching beyond just the traditional, and that's creating, right? So I think it's important, because we are more than just a safety net, right? We provide services to everyone, those who, regardless of ability to pay, but then those who are interested in getting cutting edge, yes, come here too, right? So I think that it's important to include those words.
Director Keddy?
Yeah, I have a couple comments. One is that both of these new mission statements lose the distinction or the goal that Director Curry mentioned earlier, that I thought was interesting, about moving from, I forget, but from providing treatment to standing up for wellness. And I think that that's really an important role, and we need to think about how we reflect that in our thinking about the world. And providing access to the world's leading medicine summons up images of cutting edge medicine. Good. But we really need to be thinking about this other thing too. The second thing is sort of reflecting on what Director Story said. There's a very difficult set of conundrums at the heart of Cook County Health System. And that because our mission historically in reality is to be available to the people who have no other option, that is, regardless, part of our mission. And it has to be supported by people so that they have to recognize that's part of our mission, and therefore keep giving us allocations for the care of people who have no other place to go. That in no way gainsays the point that Director Munar made, which is that to the extent people see us as the place of last resort, that becomes a disincentive for them to come. So we have these very difficult conundrums to unpack here. And I wish you guys good luck.
And I would say, I think that it is well, that is why I think really labored on this concept, what we can do, and still need to go labor more. But I think it cuts both ways. And now, having worked at a few safety nets, and it's an issue in every safety net, not just something specific to Strozier, but every safety net is, how do you balance that? And then how do you balance that translation to your team? Because you want them to keep pushing to the most advanced, and you want everyone to perform at that high level. And because we're a safety net doesn't mean you get a pass to be any less exceptional. In fact, you should be more, and you should be even better, because people are relying with you with really us, and sometimes with no alternative. So if we don't have it, then it is not going to happen for them, and that is terrible. So how we can make sure that we push ourselves behind that, so that it's a mission and a driver, is really what we're looking at, I think, to try to thread that needle and to really challenge what safety nets are, and hopefully lead that space. But you're right, it's definitely challenging. We'll see where we wind up, but I think this feedback helps us have a lot of that information and views.
Director Harrington, you have your hand up.
You're on mute, Director Harrington.
Yeah, I want to make sure I'm not jumping in front of somebody who was in the queue before me, and I've already spoken. So is there somebody that hasn't spoken?
Well, yeah, Director Prendergast I think you've already spoken, correct? You have your hand, you're in the first in line, and then Director Guggenheim, then Director Menard.
Okay. Yeah, no, sorry, I meant to take it down.
Okay. Director Harrington, should we go with Director Guggenheim first? Then?
Yes.
Okay. Director Guggenheim.
Yes, thank you. Yes, I think there's something wrong with how we are wording this. I mean, it is not our mission to provide access for all Cook County residents. Don't we mean to provide access to any Cook County resident who seeks care from our system? I mean, after all, I can't remember what the population of Cook County is now, but it used to be 7 million. I think we've dropped a bit. I mean, we aren't trying to provide care for 7 million people.
No,
What we're trying to say is that anybody who comes to us, we will provide the best quality, the latest technology, leading medicine, however we want to phrase that, with education, discovery, and innovation, and so on. But it's only people who come to us.
Correct. And that's what I think we said, universal access. We are accessible to everybody. If 7 million people,
all Cook County residents,
all Cook County. So we said we provide universal access to all Cook County residents. If they all want to come, that would be a very interesting challenge. We would have to grow fairly quickly and make accommodations. But we want to make sure that it's their choice to access us or not. But we are fully accessible to everyone, and that we are here for everyone. If they all want to use this, that's wonderful. If they have many choices, but we want to say we are here for everyone.
Yes, but then isn't that to any Cook County resident who seeks our care?
Your modification would be for any Cook County resident versus all Cook County residents. I understand.
Yeah. I mean, after all, I was socialized in a system that did provide universal access to all residents. And that plainly isn't what this system is about.
Correct. That's why we didn't say universal coverage. We just said access as a stepping stone. But I think I think your point is well taken on how we can look at the tenses. The goal was to make sure that everyone knows that all are welcome, that all will be served.
I totally understand that and applaud and second it and so on. But I mean, that's not what the words on the page are saying, is what I'm arguing.
No, I understand. I'm saying actually, I don't know if all 7 million people wanted to use Cook County as their medical home, I think we would have to be challenged to find how to make that happen. But we do want to be available to everyone, whether you're insured or not insured or everyone in between. If you want to use this, we need to find a way to accommodate that. But I understand that you're saying that it's to anybody who wants to use this. Let me see what we can do to clarify that.
Well, I think this goes to what Director Munoz was saying earlier, is that we somehow have to define or limit or who is our target audience, and the target audience is people who seek care from us.
So it would be something like to all who seek care. Let me take that back and see how we can phrase it.
Yeah, okay, I'll stop up. Yes, thank you.
Thank you.
Director Munar.
Thank you. Benefiting from the sequence of comments and concur with Director Keding that this is quite a conundrum and difficult assignment. So good luck. I think universal access probably needs to get like a little focus group or market tested to see if people know what that means. So that's one. I feel like this iteration focuses a lot on what we do, but not a lot, but still is a little, for me, it still misses the mark on the inspiration, like why we exist, and so kind of improving the health of county residents, or providing that wellness, or providing a continuum of essential services to serve the population of Cook County feels like that might be missing a little bit. When I think about our system, and particularly county care, and this is also a jargony term that probably should be market test or kind of tested as well. But I think about it as a public option, and one thing about public option, it does reframe it, because that concept assumes that you are competing with other systems and people are electing to bring their needs to our system, versus where there's no other choice. The one thing about the universal access is that concerns me a little bit. Well, one, I'm concerned that some of our audiences might not know what that means, including our staff. But I also feel like all of our competitors would say the same thing, that they're universally available. Now, they'll immediately give you a huge bill and a collection, which makes it not universally available. But they're like, our doors are open for everyone. So I feel like public option also just kind of changes the game. Like we're standing up a system that's competitive to our, competitive in the market, and people are electing us because we're a good value, and we can help them meet their wellness and healthcare needs. So, but it is a big conundrum. So I mean, I don't think a committee is going to be able to wordsmith it, but I do appreciate the chance to give feedback. Thank you.
Great. Director Harrington.
Yeah, I want to start by thanking leadership at Cook County Health for giving us the opportunity to wordsmith something, and hope that you take whatever we say with a grain of salt. I think we're trying to add value, and so. But one of the things that occurs to me as I look at it more carefully is the emphasis on medicine, which obviates the fact that we have a public health department, and there are things that we do that don't involve medicine at all. And I'm not saying it needs to be incorporated, but we need to make sure that we're reflective of all that we do. And medicine is a large part of it, but it's not all that we do in terms of a large health system. And we're unique in that sense that we have a public health department, but we also have the court center. which people don't know about. And if you talk about medicine, I don't know if medicine talks about what we do in HIV and AIDS, and the fact that we do have a clinic in the county jail. But the comprehensive services sort of gets to that. And one thing it makes me think about, and it may not be in the mission statement, but somewhere in whatever document we produce, I would like to see an emphasis on population health, which people are talking about. And so somewhere other than just the mission statement, we have an opportunity to elaborate on who we are and what we do and what we want. And so again, I would caution my fellow directors to leave it up to you to wordsmith it and bring it back to us, because we'll probably never have a mission statement, to use the word universal, it'll be universally accepted and approved by all, but we'll probably have one we can agree on, hopefully in the not too distant future.
Absolutely. And I think it is a challenge, and you know, I think this is a great opportunity for us to engage with them, where you are the community. And so we need to make sure that what we're trying to do, you are the chief focus group that can test us and see if we're in the right way or the wrong way, and then approve it for us. So I think that this is very helpful. I agree. We have to see if we can get to something that works, knowing that, like all great things, they will probably be works in progress, and we will continue to get better at them as some further iterations come forward.
The fellow directors, I rather recognize that we have still other things on the agenda we need to get through, so in a limited time here. So I'm mindful of everyone waiting, and it's very appreciated, but we do have other items on the agenda we need to cover. Is there anybody new that has a new comment that, or something different that has not been said?
There are 3 hands raised, but I don't know if those are current.
I'm sorry, the acting Director Curry, it was said several times that and this is easily correctable, that the total patients served in Cook County was as high as 7 million. The highest combined population ever between Chicago and suburban Cook County together was 5.5 million residents, and that capped in 1970. It's gone down since then considerably, but that was a rounding error of about 1.8 million. So I thought it was important.
Thank you for clarifying that.
Thank you.
Thank you.
Great. We have, I think, one more slide that just on the vision, which is kind of the lesser known companion to the mission. So we were proposing taking, you know, everything that's on the left and replacing it with what is on the right, which is to support healthcare as a human right by eliminating and disrupting barriers and inequities. So any comments on that, either now or you can send me and Israel your thoughts on that if there isn't time.
I think you're gonna get some comments. There you go.
Okay. Looks like Director Curry.
I'm sorry.
Okay. Director Munar.
I like the proposal quite a bit. I think having human rights in the vision is smart and meaningful. I don't know that you need disrupting. You could eliminating barriers and inequities. I think says it all.
All right. Thank you. Any other?
Or possibly overcoming
barriers. Yeah.
Surmounting, triumphing over it.
Director Munar, you commented, correct? And Director Story, you're next. Are you muted?
What I was just saying is I was just piggybacking. I think disrupting is going to be disrupting
No disruption, loud and clear. Director Harrington?
I like the statement, and I don't know how to wordsmith it, but I would like a stronger, and I'm trying to figure out how to, without putting a verb in front of it. It's nice that we support healthcare as a human right. I mean, I'd like make a statement that healthcare is a human right. We recognize healthcare as a human right, something like that.
You know, since it's a vision, we can say to ensure. That's one of the ideas we can look at.
Okay.
To ensure healthcare is a human right by eliminating and overcoming barriers and inequities, or something like that. We can look at that.
Yep.
Okay. And Debbie, is that indeed the last slide?
There's a number of slides. I'm wondering if they're the appendix. Yep.
Yes, they are. So that's what we had to present today. And so I know we appreciate all the feedback, and we'll take that back now and fold that into a draft, a strategic plan. Chair Taylor, you're muted.
It's Tuesday. Well, yes, whatever. Of course, it's muted. Thank you.
What's the day? What's the day, right?
Exactly. But thank you very much, Andrea. Israel, did you have any further comments or thoughts?
No. I think that's it. You know, we definitely will look at that, engage, maybe even look at transformation instead of disruption, or similar words that will help to guide that work, and we'll look at how we can change some of the language. But I think this has been very helpful to what we want to accomplish and achieve, and drive forward in a comprehensive plan we'll bring back to the board. And just truly thank you for all your time that you did, not just in the workshop, but in submitting the information and being responsive to us, and all the conversations we've had to help us create the plan that is responsive to the needs of the community. And truly thank you for all your time and effort in helping us get this together. And do want to have a special note to Andrea and her team, who have done a great job in helping to take all our information and put it together, and also to our government and communications team who helped do that, and all our service lines leads who have contributed to it. So thanks to all of them for helping us get here, and still more, the best work's ahead, which is making it happen.
It is. Thank you very much, and I echo your thanks to Andrea, Aaron, and the whole team in putting this together. As you could tell from the dialogue and the comments before, and the dialogue today, that the board is fully supportive and engaged with you in this project, in this process, and want to make sure that we do recognize the hard work and the thoughtfulness that went into this as well. I see a couple of hand raised, so before we adjourn, I want to make sure I acknowledge any board members or directors who would like to have questions or comments. Director Guggenheim, I see your hand raised.
Was indeed. Thank you for recognizing me. It has been a very long-term goal of mine in numerous planning exercises and strategic planning efforts that have gone on over the decades in this area, to amalgamate the Chicago Department of Public Health and the Cook County Department of Public Health. And I mean, maybe it's too politically fraught even to raise that at this point in our political history, but I'd just like to throw it out there for people to consider whether we should write that into a plan and think about doing that. Because so much of what we do, I mean, we've crept around the edges in some of the discussion this afternoon. If we had one unified system, it would very much streamline a lot of the thinking and activity that goes on.
Director Guggenheim, thank you very much for sharing your thoughts, and we appreciate it as well. Do any other directors have any other comments or questions before we adjourn?
I just want to thank Director Guggenheim for that comment. I do think that's really important that, you know, offering systemic solutions for health inequities should be part of our mission too. And we've dealt with this around kind of the charity care issue and the disproportionate burden that the system assumes for charity care, and that's a structural challenge too. You know, that others are doing the bare minimum, and we're by far doing more uncompensated care than any other health system in our county. So I do think that these structural responses are really, you know, that's why a strong vision statement is important, because if we have a strong vision, then our tactics that may include structural recommendations or public policy advocacy or partnerships can be very compelling.
Understood. I think, you know, I think it's important for us as Israel laid out and the team laid out to have really clear vision and mission statements, and you know, for today, not to you know, not today to do the tactics, right? But if we know what we're driving toward, we know our goals are. I think that's the most important thing for us. Any other directors before we adjourn? I'm sorry. All right, hearing none. Again, Israel team, thank you very much. We really appreciate the hard work, and all the directors. Thank you very much for your engagement, your input. It's quite helpful, and we look forward to continuing now. Actually, we have a vision and mission to actually doing the hard work, which is the hard work to actually accomplish and deliver on our goals. If there are no other questions or further discussion needed on the information presented today, I believe we are ready to adjourn on time. May I have a motion to adjourn?
So move.
Second.
Second.
Thank you, Chair. The motion of to adjourn has been made and seconded. All in favor?
Aye.
Aye.
The ayes have it. The meeting is adjourned. Thank you.
Take care.
Thank you.